one considers replacing the knee, we should always exhaust non-operative conservative treatments. When your knee is severely arthritic and causes you pain most of the time and affects your sleep and daily function, well, you need to see a specialist. More often than not, the first line of treatment is non-operative with simple painkillers or anti-inflammatory tablets. It's important to change your activity. You can go from a higher impact exercise such as tennis, running, to more of a low impact sport such as cycling and swimming. It's important to get your weight down, if possible, to unload the knee joint. It's important to consider other forms of treatment such as maybe a brace or a support to allow you to function. And there are some very good unloader braces available now. When pain particularly becomes severe, we can consider injections. These range from steroid injections for acute flare-ups to hyaluronic acid gel injections when the knee is dry to replace some of the lubricant within the knee. Newer injections such as plasma or platelet-rich plasma injections, where we take your blood and take the good, healthy platelets from the blood and inject them in the knee to try and allow the cartilage to settle down and heal. And there are also newer injections, the more talked about stem cell injections, either from the bone marrow or from the fat, but there's very limited evidence to support these at the moment. It's important to try non-operative treatments before you embark on a knee replacement, which is a major joint sacrificing procedure. Preserving your native knee joint is important, and although patients don't feel that doing exercise can help their knee, but actually by having a good, effective, prescribed exercise program that suits and is tailor-made to you can definitely help. If you maintain your range of motion and can keep your pain under control, you might be able to put off a knee replacement for some time. This is important because not all patients do well with a knee replacement. If you have a pain score that's 8 out of 10, where 10 is severe pain and 0 is no pain, then 80% of patients after a knee replacement will have a much improved pain score. They generally have very little pain, that is a score of 1 or 2 or 3 out of 10, and that's very much more manageable. 10% of patients have an absolutely brilliant knee. It feels normal, they can play sport, and they wish they'd had it done earlier. But the most important reason to delay a knee replacement is there is a real risk in some, about 10 to 15%, that a knee replacement does less well in. It doesn't feel like a normal knee. It doesn't have the same pain relief the patient expects, and the pain score can still remain high. And those 10 to 15% of patients regret having the knee replacement. That's why it's important to delay a knee replacement as long as you can, to remain at the back of a queue for a knee replacement, as with any degenerative condition, because replacing your knee joint isn't without risk. People ask me how long total knee replacements last, and it depends on a number of factors: your surgeon, the implant used, and the patient and the rehabilitation. There's some new evidence to support that knee replacements will last 20 years or more if put in properly and looked after. Obviously, if patients return to higher impact sports such as tennis and running, they're more likely to wear out their knee earlier. Having a revision knee replacement, having their prosthetic knee replacement replaced, is not without significant risk. And the success rates for revision knee replacement are much lower, and you're much less likely to continue to be very active after a revision knee replacement. So if we can, we try and provide you with one knee replacement at a time that's appropriate, and the patient has to look after your new knee, and hopefully we can get away with only one knee replacement for your life.